Okay, hello, welcome everybody. This is the Cancer Patient Lab weekly, I suppose, meeting where we have a presentation today on self-advocacy. Before we start, I want to remind everybody that this is just information, is not medical advice. I'm certainly not a doctor, and you should seek independent medical advice for your particular situation. Also want to remind people that all of this is public. It'll be posted on our YouTube channel. So if you do ask questions, that will be made public, or if you otherwise identify yourself. And finally, the Cancer Patient Lab is a 501c3 nonprofit organization that is supported through contributions and public support. So if you like what we're doing, please contact us in the show notes, and we can let you know how you can make a donation. So today's presentation and discussion is going to be led by Madison. He's the president of Genomic Selling Solutions, and he's going to lead a discussion on how you can build your knowledge around precision medicine and advocate for your care. He's led sales, product development, and strategy in cancer diagnostics for more than 20 years, including the very first molecular assay to help oncologists personalize adjuvant therapies. His father's a cancer survivor. He was able to be in a surgical resection and follow his tumor tissue through the diagnostic pathways to ensure he had precision medicine. So thanks for being here, Rome, and I'm going to let you go ahead and take it away.
Thank you so much. Thank you, Brad, for just your partnership, being a champion for other patients and for innovation in the space. I thank all of you guys for taking the time out to join this. I'll tell you off the top, sorry to disappoint you. I'm not a doctor. I'm not a scientist, but I have been in this industry long enough to see its infancy and grow and evolve with it, grow and evolve with the science, and also grow and evolve with the literature. And so I've been in leadership, building companies, launching new diagnostic tests that informs cancer care for the greater part of 20 years. Today, what I do is I have a podcast called Genetics for Healthcare. It's a podcast for patients. And our goal is to inform and empower patients in ways to advocate for themselves and their doctors for precision medicine approach to their care, and empower and prepare those patients and their family members to be a more effective partners in their care. And I met Brad some time ago at the Harvard Medical School at a think tank. And Brad at that time was getting treatment, and his hair looked like mine. And he made a statement to someone who was an administrator, a high-ranking administrator at one of the medical schools there, who was there, I say pontificating, I might be a little cynical, but he was talking about the great approach that his institution does, how they sequence everybody, they consider genetic information. And I was just struck by Brad's courage and how he stood up and said, yeah, I love your institution and being true there. I'm sure it's great, but I'm just here to tell you what you're saying is not happening on the front lines. And I just thought it took a lot of courage to do that. And I went up to him, and since that time, I interviewed Brad for the Precision Medicine podcast, the first podcast we started, and the goal of that podcast is to raise the knowledge in the industry. Like, how are we going to make all of this available and affordable for patients? But it ended up being an industry conversation. And after years of doing that successfully, and it grew, and I think it contributed to the increase in awareness of folks in the industry and the clinical utility and uncovering some of the problems. But the one thing that has been missing since that time, since 2018, when I launched that podcast, we've had explosive growth. We've had tremendous innovation in the space. But the things that remain the same is that patients aren't getting access to these innovative therapies. So that's why I do what I do today, and this is what brought me on here to talk to you guys. So I want to give you a little background on why I got here, because I'm going to tell you off the top, I have an unreasonable amount of confidence that we can not only cure cancer, but we can, in some cases, whether it's rare disease or late stage, we can make this a chronic disease. I have an unreasonable amount of confidence because of the way I got here. This started now 22 years ago. In my background, obviously, it has nothing to do with cancer. Again, I'm not necessarily a scientific person by training. Um, there was a year where I was unemployed. I've always been in sales, I've been in healthcare, but there was a year where I was unemployed. And I grew up, my mother raised, 3 kids as a single mother. She graduated from college, University of Texas, with her degree in business while working full time. And that stress on a single woman to take care of family and be the breadwinner and all those things took its toll on my mother. And she struggled with her mental health for the balance of, my life. And at this time, when I'm fully grown, my mother's an empty nester. I found out that my mother had really spiraled, and being away, I didn't understand the depth of what was going on. um, she lost her job. She eventually lost her home. And my mother actually spiraled into a lifestyle of homelessness. And I can't tell you, there are no words to describe like what that feeling or your view of self and all those things when you go to bed at night and you don't know where your mother is. This is during the time that I was unemployed. My brother at that time was going to school at Baylor University. He drops out of school to try to help my mom, thinking he's trying to help my mom, and he starts selling drugs. Of course, we know how that ends. He gets busted and goes to jail. It was during that time that I got the opportunity to interview and work for the first company that was doing any type of precision medicine, and we just called it, molecular oncology at the time. But the benefit was I was unemployed. I had nothing else to do but prepare for these conversations. And so I actually went to Barnes and Nobles and Borders books. We remember we used to go to bookstores to have a cup of coffee. Now we go to coffee stores to read a book, right? So back then, that was my homework. I was unemployed. I didn't have the money to buy these books, so I would go and study and copy out of the books and put them back on the shelf. The long and story is, and I won't, belabor that. I ended up getting the opportunity. That company was called Oncotech, and I'll fast forward the story on my mother and my brother. My mother suffered from homelessness for 11 years, not because she didn't have a place to go to, but that's just kind of the state that she was in. What stopped her is she had a massive heart attack. We were able to get her to hospital, get her care, and she was in a assisted living place for 7 years. My mother passed away in 2023, surrounded by family and friends. That story alone is one of the reasons why I have unreasonable confidence in what we can do in this industry. Because after all those years of suffering and having anxiety about what's going on with my mother, I still had faith that someone was looking out for her and that a better outcome can come from that. And it did. My brother is an electrician today. He turned his life around. He went back to college. He got his bachelor's degree, and he's doing well. At the time, working for this one company, I had the privilege of selling the first assay that informed doctors on how to treat cancer patients, on what's likely to benefit them or not benefit them. And it was a fresh tissue assay, which meant that when a patient is getting their tumor resected, we had to take a piece of that tissue in order to get this molecular genetic information that we can get today through an archive block or blood. But it needed that then. The reason I mentioned that is that I that was the first company that I was ever doing any type of personalized assay to help, personalize, cancer care. I have over 20,000 hours in the operating room watching tumors being removed from the brain, breast, lung, colon, every organ in the body on patients as old as 90 years old and as young as 9 months old. And I will tell you, of all those hours, watching surgery, working with doctors, and these are the early days, It took a monumental effort to get one person to say, yes, I'm going to adopt this. And even when they adopted it, I had to be there to train the folks in the operating room, the pathology department. And then when that report goes back, it goes back to the treating oncologist to sit with that oncologist to help them understand how to use these genetic insights and apply them to the care for their patient. And the reason I say that is I have a tremendous respect for, healthcare providers who will go the extra mile, who will ask the extra question, who will do those things that may not be convenient, may not be easy, but they will take the time to ensure that patient understands that. Unbeknownst to me, I mentioned to you that my mother raised us as a single parent. I didn't have a relationship with my father until I was 17. But 2 years into working in this field, my father was diagnosed with colorectal cancer. And I remember in the hospital system that he was in, again, I did this every day. I was there working for somebody's mother, brother, father, cousin. All these patients meant something to me. I saw them as, someone who needed to be guarded and to, be their warrior to advocate for their access to this information. And now it's my father. And fortunately, the surgeon was my customer who was going to perform the surgery on my father. And I didn't have any expectations. I knew that I was going to, advocate for him to get this type of testing. And that surgeon called and said, "Hey, do you want to be there for the surgery?" And of course, I jumped at the opportunity. Yeah, I work with this guy. I do this all the time. So it's a little different because, to me, it was just like any other day. And I had all of my family out in the waiting room, with bated breath hanging. And in that moment, it was just so surreal. I was just so grateful to be in that position for my father, to advocate for him. Seeing the tissue, when he took the tumor out, he showed me, "Hey, this is the tumor," following that tumor to the pathology department and watching them give the white glove service. And I understand everybody's not able to be in that position, but again, for me, it was surreal. When the report and his biomarkers came back, I understood that he stood a good chance of responding to the therapy that they were going to give him. He was not going to be resistant to any of those. The biomarkers were favorable. And my father today is 21-year colon cancer survivor. He had a good molecular report. Um, so I wanted to give you that background to help you understand how unreasonably confident I am that each one of you can use genetic insights to get the care you need, to advocate for yourself, and also share these insights and experiences that will empower someone else to advocate for themselves in that way, because it can save their life and certainly save the lives of future generations in your family. I just got to be real with you guys. Like, you know, I just believe that we don't accomplish things sometimes because we just don't think big enough. I am a realist. I know that life is a vapor. My favorite book says we're not here long. So it's not necessarily our breadth of years, it's our depth of years. How much impact can we make? Not only on our family and the people around us, but your faith and your fighting and your advocacy can make a larger impact on the world around you. So I encourage you guys to ask those questions and do those things. So I'm going to share with you my screen because I've had the great privilege to interview a number of people for Genetics for Healthcare, my current podcast. Let me see here. I want to be able to share my screen if okay. All right, here we go. So I'm just going to share with you, when I interview patients and experts for Genetics for Healthcare, at the end of our conversation, I'm always going to ask them, what are questions that patients can ask their doctor, their care providers, to advocate for themselves? And many of the questions, at least in these first four episodes that I'm going to show you, are from different perspectives. I would imagine at some level the same questions come up, and I would really assume that because you're here, you guys are a lot more forward with your conversations with your doctor. So these may be questions that you've asked, but I will ask you if there's questions that you don't see that you feel are great. Um, please let me know what they are because we want to share them with the world. And so those questions that I asked, and this is Steve Pickett. He's in the Dallas-Fort Worth area. He is a CBS reporter and anchor. And his story is unique because obviously being a journalist, he makes his living with his voice. So he was diagnosed with prostate cancer, and a year on the end of that treatment, he was diagnosed with throat cancer. And so he was still being treated for his prostate cancer when he developed throat cancer. And he shared his story on my podcast. And I asked him, what are questions that you can ask? He has a ton of questions because he's a reporter. That's what he does. He asks questions for a living. And he said, ask the doctor if they're telling you something you don't understand, stop them and ask them to explain better. He says, educate me because I don't understand that terminology. And it is common that doctors see patients over and over again in the day. They speak doctor speak. This is just second nature for them. And a lot of times patients might be in a position where we don't stop them because, we're just listening as intently as we can, or the information is just washing over us. But I think that's important because I believe that, people only understand something to the degree that they can explain it to someone else. And if you're using a lot of big terms and medical jargon, that just is not helpful. I didn't go to medical school. So if you really understand this, you will help me understand it. Another question that Steve suggested is, and he said it this way, he says, please explain to me, tell me what I don't know in a matter that I can know it. And I think that's a pretty detailed question that says, say what you just said in English. I am not a doctor, I'm not your peer. So help me understand, and I'm not going to leave here until I confirm with you that I've understood what you said and the implications of that. All right. Some of you might recognize this handsome gentleman. I had the pleasure of interviewing, as I mentioned, Brad for this podcast, which will air this week. It's on YouTube now, but we'll do our social media push in the next 24 hours. And what Brad has mentioned is, what additional data can help personalize my care? Information in and of itself is not powerful. Applied information is powerful. And so it's one thing for a doctor to say he has information, but he needs to explain, he or she needs to explain what that information, the potential of that information is. How can it be applied? Another thing that Brad mentioned in our conversation are asking the doctor, are there any other tests that I could or should get that would help guide my care or identify additional treatment options? And what we're talking about here is diagnostics. The fact of the matter is there are many diagnostics available for patients. In many cases, they're covered. There's a clear indication, but the patient is not told about it, or it's just not ordered. Or in some cases, and there's data on this, these tests are ordered and it may reveal that a patient is a candidate for therapy, but the patient never gets the drug. And I understand there's many different reasons why that may be the case. But again, a question you should ask. And then can I get a second opinion? And I think that's key because you want to know that your doctor is for you in your health, in your choices, and that he's willing to be a good partner with you for your health. And there are stories that I've heard that, doctors becoming offended, like, you're questioning me, like, wait a minute, I'm the patient, right? you're working for me. And we just want to make sure patients understand that their voice matters, and don't hesitate to use that voice with your care providers to get more clarity and to ensure that they're working with you and they're going to be a partner. Uh-oh. Still there? All right. Victoria Gray is the first sickle cell patient that was treated with CAR T therapy, cured of all of her symptoms. She was treated, first patient one in the clinical trial in 2019, and she has not had symptoms, the pain associated with sickle cell since then. Fantastic story. That will come next week. Now, she's not a cancer patient. She's diagnosed with sickle cell at 3 months, but her questions are still highly relevant for any patient. So she suggests, what options can you provide for me besides, in her case, it was pain medication, but sometimes with lung cancer diagnosis or others, there's targeted therapies, there's immunotherapies, there's clinical trials, but what they're offering is chemotherapy, traditional chemotherapy. And that's a good question to ask to see what the breadth of treatment options might be. A second question is, if I tell you that a medicine is not working for me, will you listen and change it? And third, if you feel you can't help me, will you recommend other places with more advanced capabilities? And she happened to be living in not rural Mississippi, but it was certainly small town Mississippi. And they just didn't have the capabilities to give her the care that she needed. And in this case, she didn't have the language to ask those questions. So very important. Carlo Bafulco. Dr. Bafulco is the chief medical officer at Providence Genomics. He is a pathologist, scientist by training, and we talked about the role of making sure patients' tumors are getting comprehensive genomic profile as early as possible. Great questions that he suggested is asking your doctor, what's driving my tumor growth? And that reflects on diagnostics. It reflects on a genomic profile for your tumor. And it's important to ask that up front, because if they don't know, there's ways that they can know. And you just want to make sure that they're on board for finding out. What are the consequences of this diagnosis for my family? That's a major implication, because many times, as I don't know what your experience has been, I always ask patients that I interview, were you offered germline genetic testing at any time to find if you have a genetic, predisposition for developing tumors or cancer? And it's like 60-40, no to yes. They're just not being informed of this. And then, are there any clinical trials available for me? And if they are, how will you find them? Because it is the case that geographically your institution might not have clinical trials, but there are other institutions that have clinical trials, and they might not be able to find them. They may not suggest them because it's not in their network, whatever the case may be. These are ways to ensure communicating to your doctor that you want them to be a partner for what's best for you. And then here's some additional questions. And this is all centered around diagnostics, because, genetic information is a way to unlock, innovative care, clinical trials, and insights that can help, future generations of your family avoid a cancer diagnosis, or at least detect it early. And it's not just limited to oncology. It is spreading to other diseases like cystic fibrosis, neonatal care, neurologic disorders, and others. But these questions are relevant to all of those situations. If I don't need biomarker testing, why not? How will biomarker testing be done? Is liquid biopsy an option for me? Which biomarkers should be tested? What can they tell? What can they tell us about my cancer? Not you, us. Can I get a copy of my biomarker test report? That's a big one you want a copy of. Will I need to have biomarker testing done? And if so, when redone? How much will the biomarker testing cost? And are they covered by my insurance? And if it's not covered, what options are available to get this information and not cause financial toxicity or, excessive debt? Again, it's my goal here to really arm you with questions. I would certainly imagine that being here in this environment amongst these leaders, you guys are probably asking these questions and others that I may not be aware of. But I want you guys to know that you have a lot of people fighting for you, whether that you may not know. We want as many patients as possible to have access to these innovative therapies, this genetic information, and to ensure that they are working with healthcare providers that have their best interest in heart and are willing to be your partner to do the things that you want for your care. I'll stop there, and I will leave you with the idea that, again, I have an unreasonable amount of confidence that this can become, mainstream, that we will get greater access to this, and through your experiences, someone's life is going to be better.
Okay, thanks very much, Rom. I'm going to open it up to questions. Please use the raise hand feature if you have a question. And I see Cindy has a question, so go ahead, Cindy.
Hi, Rome. Thanks for this really inspiring, conversation. I too have like crazy, unreasonable confidence that we can diagnose cancer better and act sooner and eventually get to a pretty, overarching cure. Not easy, not quick, but I really do as well. Where I disagree with you, and this is to spur an interesting conversation, not to be in any way critical, is that the answer is going into one's doctor's office with all of these questions. I'll tell you why. So I recently had to do a biopsy. And I know, and this is at MSK, so in New York City, there institutions are not set up as they are now to spend time with patients in the way that would be necessary to get these questions answered the way one would need that. Most patients don't know how to ask these questions because you have to have a lot of background knowledge also to understand when you're getting the right answer. I think they're the right questions, and I think there are answers to those questions. But I don't think that most of the doctors, and I'm not trying to be negative, we can get into that's a side conversation as to why, just to say that there are people out there. The question for me is, how do you get to the people out there that answer these questions in the way that would really move a patient? So I'm talking now sort of, institutionally, but it's almost like, I think we should stop looking for, we go in, we advocate for ourselves. We need different kinds of doctors that are going to value, these questions. In fact, if they did, they would be coming to us. We wouldn't have to ask them these questions. So I know that I don't have the answer and you don't have the answer, but maybe what I want to say is, do you see standard of care medicine changing or other places in medicine changing enough where one can go in and have this conversation? So one, do you agree with my premise? Do you disagree? And do you think that overall we're moving in the right direction? That's my long-winded way of asking simple questions.
No, I appreciate that, your feedback, Cindy, and point well taken. So yes, you're correct. The current system is not set up too, because doctors only have so much time. And again, patients may not have the background knowledge to know whether an answer that they get is accurate or not. What we're doing here is the idea of spurring the dialogue, because right now these conversations broadly don't seem to be had, because the numbers show that patients are not getting access to this testing, even when there are clear indications through guidelines and in many cases coverage through insurance. So getting the information out there to start a dialogue with the doctor, I think, is important. I think also, if that doctor doesn't have the time or doesn't have the answers, at least that doctor will make a point to follow up or refer you to someone who can answer your questions. Because in my opinion, that's how they partner with you. They may not have, the answers or be the solution, but if they know you're searching, at least they can be a partner in helping you get the answers that you need, and hopefully discuss them together, whether it's an advanced practitioner or a genetic counselor or any other type of patient. The goal there is to start that dialogue and to help them understand that it's important to you, that you're partnering and giving you the care and attention that you need in that care. I hope that makes sense. But yeah, I would not say that this is kind of end all be all, but the goal that we're trying to do is start that critical mass of questions, because the healthcare system will only get there with demand, right? If patients are asking these questions in my language, making their doctor uncomfortable, that's when things happen.
Okay. All right, thank you. If you have a question, use the raise hand feature. One of the things that you said that kind of strikes me, you mentioned the example of the patient who was in a small hospital and might not be getting the best care. And the more I get involved in this community, the more I think that is just so true. You can go from one hospital to another and get standard of care can differ, right down the block. And I'm just wondering, from my perspective, I feel like, and I don't know if you agree or disagree. I mean, should a patient be in a very large, university affiliated medical institution if they have cancer? Or are you, where they're, I think, I don't know, maybe they're less likely to be flexible on some of the things you're suggesting, or does it really matter? What's your experience with that?
So my experience is accurate. So I've covered the continental United States, managing teams, talking to doctors, going kind of everywhere to talk to physicians about adopting these innovative tests and therapies. And so I live in Texas, for instance, and a big customer that I've worked with in the past has been Texas Oncology. Just take one instance, right? So referring to genetic counseling for germline genetic testing. Well, of their 600 locations, I don't know, 400 locations or whatever. I don't know how many they have now, but as of 3 years ago, I think they had 6 genetic counselors. Like, and the wait to talk to a genetic counselor is 6 months or more. It's not standard that the care would be inferior, because those doctors have the same access to the therapies and information that large academics centers have at a base level of treating cancer patients. But when you're talking about advanced cancer clinical trials, understanding what's innovative, the academic centers, you're dealing with a specialist. So your community oncologist who sees and treats every cancer, every tumor that comes in the door, may not have the same experience and knowledge of treating head and neck cancer as a head and neck specialist at MD Anderson or UT Southwestern here in Dallas, because they see that all day, every day They treat that. That's all they deal with. They know the studies, they know the data, they know what's coming. And so in that way, it can be an advantage. However, when you're going into the community setting, it's good to ask those questions because they may not be as forthcoming because again, they got 30 patients they have to see. I've got 15 minutes with you. I just want to make contact and get you started and let you know that we're going to care for you. But again, introduce those questions because it might start a larger conversation or get additional resources that they have available to you sooner, or refer you to someone who has a little bit more knowledge that can inform your care. But again, I think the thing is we don't know what we don't know, right? And so going into that situation, we're just there for the doctor to speak to us, to learn what the doctor has and what their perspective is and what their plan is. So this is why we do this, to build community, to encourage, others to be empowered through information to ask these questions.
Okay. Well, going to the chat, I won't read the entire comment, but there's a part of it that I think is particularly relevant here. It says, should they have done more molecular genetic testing on new tumors, or can you assume they carried the same information? And the reason that's relevant, I know that when I was in treatment, I got a stamp report, which was genetic testing, and it kind of said, here are the mutations. And nobody told me there was anything more than that. I learned that through Cancer Patient Lab. And through Cancer Patient Lab, I found Tempus and Boston Gene and the proteomics report. And every one of them had a little bit more information that was super helpful. So, there's always a question here, how much testing is enough? And I think people might get a false sense of security once they get the genetic testing and they get one report and call it a day. So that's just my comment. I don't know if you have any response to that or not.
Yeah, it's a very good comment because there's in my conversation with Carlo Baffolco, he talks about the variability and the unwanted variability, right? So there's variability in testing where upon diagnosis, they may run 2 or 3 biomarkers and wait for a comprehensive biomarker test that might be 500 to 1,000 biomarkers at later stages of disease. Well, if you're talking about, a lung cancer patient where you can't get a lot of tissue potentially, well, why don't you run the 500 gene biomarker test so you can get as much information up front as possible that might inform care? Another reason or another thing, something to think about here is many times, and we're talking about germline genetic testing, and those are the genes or the gene mutations that you're born with, you're inherited, versus the genomic tests are those mutations that evolve through any unknown reasons. They continue to evolve through drug pressure, through just the evolution of how cancer cells continue to mutate, and they want to become immortal. So those mutations can increase between, first line therapy and recurrence. So upon recurrence, it may be wise to, get another profile on the tumor tissue that exists. But then that presents challenges in itself because they may not have access to the tumor based on where those lesions are, or it may be harmful or dangerous to try to get tissue in order to get that information. But there's still liquid biopsy available that may be an option. So again, at every turn, we just want to go in and ask these doctors the questions so they can share with us what we feel is available. But indeed, it's advocacy, it's self-advocacy. We have to do the work, the research for ourselves, get folks involved. This is a great forum to come back with some of those answers to questions to vet that.
Okay. Rick had a comment, and it's kind of similar to Chris's. Rick's comment is, we cannot control the doctors, so we have to advocate for ourselves. At the same time, ANCAN is working with diagnostic companies to do a better job educating doctors. Rome, you started out in diagnostics, I think. What is that field looking like now? It just seems to me that there's just really the technology has maybe gotten too good even. It's picking up noise at this point. Can you talk a little bit about that?
I think that's it's the realization of that unreasonable confidence that I had years ago that we can make progress. I never saw like AI coming. I never saw next generation sequencing coming. I mean, when I started in the business, again, that was like version 1 of the test where you needed, fresh tumor cells to be able to get this genetic information, this type of genomic information to inform care. And, now we can get this information any number of ways. And the way that AI is coming into the space, I got to admit, I was a little, leery, kind of suspicious, like, okay, come on now. But in terms of workflow, in terms of the timely intervention that is needed at a point in time in care, in terms of physicians who may not, that physician who lives in, Durant, Oklahoma, who may not have the knowledge about pancreatic cancer as, the pancreatic cancer specialist at an academic institution. Well, that can help, bridge the gap for those doctors who are in those situations. So I think it gets us, faster to a tipping point to where this information is readily accessible and we can integrate these genetic and genomic insights into our healthcare, and not just one time. It can be in our record. We can own those records ourselves as patients and take them in a way that's just not a PDF report that the doctor doesn't have time again to thumb through. But I think it can be very dynamic in the way that technology is advancing diagnostics today.
Anybody else have any questions here? Okay. I do want to relate one experience I had for you to give you an example, kind of to double down on what you just said. So I got a proteomics report that I learned about, again, through Cancer Patient Lab, long after my chemo and my surgery, and I managed to have some tumor tissue still sitting around. And I got this big, thick report, and I didn't really understand it at all, even the summary. And I gave it to my oncologist, who is a really good doctor. I got really good doctors. And he emailed me back and he says, "What am I supposed to do with this?" He says, "I don't even understand it." That's what he said. And I took it to one of the cancer scientists that works pretty closely with Cancer Patient Lab. And she says, "Go back to the oncologist, tell him to look at page 3, line 26, and just tell him to look at this specific thing. Just tell him it's trope 2, and this is the treatment." And I went in and I sat down with him in person and I, kind of highlighted, and I said, "I've been told to tell you to look at this." And he looks at it for a minute. He says, "Oh, you have that." So, okay, we'll know what to do if this recurs. And that really struck me that I had to do that much work, to find out that I'm a candidate for targeted therapies, or I might have been. I don't know. Is my experience unique, or is that kind of how it is out there?
It's not unique, and that's the importance of having these conversations, because somewhere, if we're seeking, I think we'll find the information that we need and that we're looking for. And listen, it's so important that it's important to me that a doctor says, "I don't know," right? So I was talking to Steve Pickett, and he mentioned that his wife doesn't like his urologist because he says, "I don't know." You're a doctor, you're supposed to have the answers. But, to Steve, it was like, that's important to me to know that someone's willing to be transparent about what they don't know so we can together find out. So it's unfortunately not uncommon that they may not know or be familiar with these insights or these new diagnostics. And it's also unfortunately not common that many in your position don't continue to ask and seek that information. So kudos to you and kudos to your doctor for working together.
Okay. Anybody else have any other questions that you'd like to ask? Okay, Rick Davis has his hand up. Go ahead, Rick.
So we run across patients in several different diseases who frequently have to inform their doctors, sadly. Usually this is not at centers of excellence. I suspect that Roger was at a center of excellence and it happened. Can happen at centers of excellence, but it's less frequent. But at the same time, an educated patient is going to get much better treatment than an uneducated patient because they're going to know what tests to ask for, and they may possibly know about certain precision targets that the doctor hasn't come across before. Because, I mean, doctors, after all, are human. There's a couple of issues that this raises. Number one, I think if you can, try to get to a center of excellence. By and large, you're going to get better treatment. Number two, try and stay on top of at least the basic tests. One of the things that Hazel's raised a couple of times is, how often do I need testing? When should I get testing? A lot of that depends on your disease. In prostate cancer, for example, somatic mutations change all the time. Many years ago, when Medicare first approved somatic testing, it was once in a lifetime. And we went back and we campaigned with Foundation Medicine and others, and they changed it to as needed and recommended by the doctor. So now, in some cases, you may need to get somatic testing every 6 to 9 months, because the cancer's morphing constantly. It's changing, it's dynamic. And so mutations that you had 3 years ago may not be the mutations you have today. And with precision medicine, you need to know what you have today. So I don't know enough about ovarian to know how quickly it changes there, but that's the conversation to have with your docs. How frequently do the mutations change? It sounds to me, Hazel, like what they're saying is, well, if you have recurrence, that probably means that the mutations might have changed. One thing, just for your information, is that they pretty much have found that liquid biopsies and tissue biopsies are consistent. So whatever you find in your liquid biopsy is most likely going to be found in your tissue biopsy, certainly if it is a soft tissue. There's a problem with tissue biopsies from bone because they've got to macerate the bone, and that can mess up how the mutations show up. But ideally, especially as the technology improves, what they're collecting from blood is going to give you the best view. The only other thing I wanted to say, Rome, is I put a note to you in the chat window. Hopefully you'll look at it. We do a lot of work with renal medullary carcinoma, and we'd love for you to give that a plug when you interview Victoria Gray, because it just doesn't get enough publicity, and it's just a nasty disease which is correlated with sickle cell trait.
Thank you for that information.
Yeah, I think Rick was focusing on Hazel's comment that her oncologist and surgeon said they discouraged her from getting a liquid biopsy. They said the information could be incomplete and confusing and won't lead to anything useful. And Hazel says she was talking about CTC testing. Are you able to comment on some of the specific types of liquid biopsies that are out there and how they compare? Because maybe that's what they were reacting to, was the circulating tumor cell tests.
So there's limited data on CTCs and specific diseases, and that's many times what clinicians are going to look towards, is like, in the disease that I'm treating, how do I apply that information? But I will say that for a doctor to, yeah, for a doctor to say, well, it's not going to help. Like, how would you possibly know it's not going to help? Right? Like, how would you possibly know if I'm your patient and I'm asking you about it? I mean, I would want you to say, listen, I don't have a lot of experience with it. I don't, I've not heard any, data that's compelling for me. But if you feel that it's useful, let's look into it or something. But I don't want a doctor to summarily dismiss it because he may not be familiar with it or hasn't had great success with it. So
Yeah, more than
yeah.
that, like, I want to know, why, just,
Well, I'll say this. I mean, I was talking to a breast cancer patient, and that patient goes in and says, "Will you be doing genetic testing for me?" And the physician said, "Oh, you don't need that." All right. Well, why not? Like, well, it's not going to change what I do. Okay. The answer was, it's not going to change what I do. It's not that it's not beneficial for you and can be informative to you. It's that I'm not going to do anything with it. So again, we're talking about advocacy and to arm yourself to say, hey, are you my partner? Are you treating me? If I feel the information is useful, even though you may not use it, someone may use it, right? And so this is why I want it. And so I'm always, very, I don't know, I'm very, curt with physicians who just summarily dismiss things when you're supposed to be working on my behalf. I don't know. So that's just me.
so Rob's had his hand up for a while. Go ahead, Rob.
Yeah, I was curious as to how much advocation you see for nutritional, looking at it from more of a natural side as far as nutritional and supplement, and working. Most doctors don't seem to have the expertise or the knowledge behind how effective those methods can be. What are your thoughts on that, and how to be able to approach a doctor with information and relevance on that, and get some sort of productive feedback?
Well, I'll say first that I'm not quite sure that many, MDs who, Western medicine trained will take that into consideration. There's just not many. It's not a part of their guidelines. It's not a part of their training. So they may not be as receptive. Certainly some will be. But I will also tell you that I'm married to a naturopath. And
Fantastic.
she is all about it. And so there are naturopathic, clinicians who will, give you a consultation on the different holistic or, nutritional things that you can do to help fortify your immune system, build your strength, and fight disease. So I will tell you that I'm in favor of all of it because it's just information. Is when is more information a bad thing, right? And so if it's
I
something that
agree.
I
Well,
can do,
that's what we do with what I work with. I actually use artificial intelligence to develop targeted end of one protocols related to the specific mutation, and hopefully we can have further conversations about this. But and using that as a template to share with doctors, I'm hoping that with the information we provide with the client, sharing it with the doctor, we can bridge a gap in that respect. But your wife would find this very interesting, I believe. We have a naturopathic doctor on our team and nutritionist as well. That the relevance of that type of information is seeming to have pretty significant success when combined with conventional Western medicine.
yeah, it does. And so I live it anyway because she cooks for me. So
Absolutely.
yeah,
That's
and I
right.
want to circle back around really quickly to Hazel's comment, in the question that was asked around, Roger asked around other types of diagnostic tests, things like that, CTCs versus circulating tumor DNA. The data is progressing quickly with circulating tumor DNA, otherwise known as MRD testing, molecular residual disease. Some call it minimal residual disease. It has many different applications. And the evidence behind that is, seems to be more robust than circulating tumor cells. But even though I say that, the adoption for MRD testing is extremely poor, Doctors aren't familiar with it. They don't know what to do with it. Many times they might hesitate to order because like, hey, let's do this first. And so again, more advocacy is needed to ensure that these doctors are willing to be, our partners in our care.
I don't find the hand feature, so I hope I can chime in. Cindy, you have your hands up for a while. Is it okay if I comment on that?
Of course.
Okay, and I don't know why I don't find this feature. Because I wanted to comment on this liquid biopsies and additional testing, and I put also a little bit on the comment actually for Hazel. So first of all, especially, so in general, genomic testing often doesn't yield actionable information. So if you look at the NCI match trial published by Keith Flaherty from Harvard, only 1 out of 4 patients have actionable mutations. Number one, that's a real problem, which is one of the reasons why SAGE is doing functional precision medicine, the next generation of oncotech, which you might want to hear, Rome. But the other part is, if you have a rare disease, why leaving the stone unturned? So if you have a rare disease, especially then, I want to have the genomic test, number one. Number two, I'm not very familiar with how well now the liquid biopsies are correlating with the solid tumors. There were initial reports that didn't show very good correlation, and there were certain concerns about the validity that probably has now been overcome in the last 10 years, I would like to say. I would like to hope. So in general now, probably the liquid biopsy would be the next part to look at circulating tumor DNA. And I would definitely do that. That's relatively easy to do. It's more or less non-invasive. When it comes to circulating tumor cells, they are usually circulating, if in a 10 ml vial, you get probably a median of about 40 cells with a really good isolation technique for tumors that are late stage, phase 4, that are heavily shedding, such as prostate or breast cancer. But for most others, it's relatively rare, and so you actually only have a few number of cells that you can actually isolate with a circulating tumor cell. So that's probably not the most viable approach. So I do think that it makes sense to do a liquid biopsy to look, screen for actionable mutations, and see whether there are any. There's nothing to lose from it. So I fully agree with you what you're saying, Rome. And the second part is you mentioned the MRD, the minimal residual disease, and so there is Signatera and Personalis. Now I saw that Hazel is in France, and I thought, okay, Santeria, it doesn't matter. But the challenge is Signatera is not basically on the standard panel yet. And they're doing a phase 3 or whatever study with colorectal cancer patients in France that's currently underway, and they're doing some assessment. But I would think that if you live in France, you probably the only way to get Signatera then would actually be to contact the company, and it will likely be an out-of-pocket pay. That's kind of what I think is the thing. And I do think Signatera, and I've heard also Personalis has an even superior technology, are really impressive technologies to monitor your progression of the disease or whether your tumor is really responding to its treatment, because it's really important not to treat with drugs that will only hurt you and can't help you.
Okay.
Hey, I'm gonna call you. Glad you called.
So Cindy, you want to go ahead?
Make it very quick. Again, I think that these are the right questions to be asking.
Much rougher
And I'm
than
all for patients really advocating and learning how to advocate for themselves, and that's like a very long process. And I think sometimes in terms of advocacy, patients help each other and find out, hey, I have pancreatic cancer, and like on a chat board, this is the best person to see because they answer all of these questions. I think patients often lose time asking questions, not getting the right answer, taking a while before they realize they didn't get the right answer. And now maybe a month or two has passed. It's putting a lot on the patient to figure out what the right answer is. If they got the right answer, I worry for patients. I work with patients. I worry for them. So this is a question actually for Brad. Brad, do we have, or why don't we have, or could we have, or should we have almost like a repository of, doctors in various areas, pancreatic, prostate, et cetera, breast cancer, that are the kind of doctors that are already there. You don't have to create them. We have enough experience amongst ourselves, and, it's probably collectible, from others who are not part of this group, of beginning to put together that kind of a resource. So that's my question.
Yeah, unfortunately, Brad is not here. But
You see, but I never know names and faces, so you're the guy who's in charge.
oh, well, we're working on that. In fact, behind the scenes, it's a challenge, but we've got, Brian, when he was alive, he had done a really good job of putting into spreadsheets all of the partners that we work with. That's how I found a proteomics test, for example. And we're in the process of making the Cancer Patient Lab a much more robust resource right now, and including those sorts of directories with comments and feedbacks and things like that. So it's a long process, and it's all volunteer driven, so it takes a little longer, but stay tuned.
Yeah, that's great.
Okay. All right. Well, with that, we are a little past time. I want to thank you, Rome, for being here. Thanks everybody for your comments and your questions. Rome, I put your website in the link, in the chat, the link in the chat, so people can find you and can subscribe to your podcast and follow you and reach out to you if they'd like to talk further. I think a couple people do want to do that. And again, this has been recorded, so this will be on the YouTube channel, and we're going to put these links in the show notes as well. Thanks, everybody. We'll see you all next week.
Thank you all.